endovascular surgery, non-profit edition, and thank you.
Thank you, Professor Omar Kashif. Any question? For the sake of time, the last talk will be postponed and the next session coming now. Thank you very much.
دكتور أيمن بيه اتفضل. اتفضل يا بيه، اتفضل. دكتور أيمن فخري اتفضل يا باشا، اتفضل.
It's my pleasure to introduce my friend and colleague, Dr. Mosaad Soliman. He will talk about pelvic congestion syndrome, the unsound issue.
السلام عليكم. الحقيقة it's very difficult for any lecturer to give a talk of Dr. Omar Kashif. He is such an insightful and a magic academic researcher. I wished one day to be under his mentorship. الحقيقة موضوعنا بعيد قوي عن الكاروتيد، احنا تحت خالص، احنا في البلفس. وليه في البلفس؟ عشان ده من المواضيع اللي ما اتحلتش. يعني الكاروتيد اتحل، الايورتا بيتحل، لكن الحقيقة البلفيك كونجيشن الى الان مشكلته ما اتحلتش، واحنا بندور هو ليه ما اتحلتش الموضوع. First of all, I have nothing to disclose. If we are talking about a disease with unclear etiology, is it a mechanical because of the gravid uterus that increases the pelvic pressure and the pelvic blood flow 60 times during pregnancy than in the normal situation, or it is hormonal because of the progesterone, which causes relaxation of the vein wall and causes this congestion? It's unclear so far. We are talking about the absence of a definitive diagnostic criteria for such a disease, and we are talking about the limitation of evidence-based approach of management and uncertain optimal treatment. Then we are talking now about the pelvic congestion syndrome, which affects around 8% of the females in the childbearing period, and it reaches around 23% of the Middle Eastern population, and this is far away higher than in the worldwide incidence. That's why, because in the Middle East they have what we call the traditional taboo. They are shy to expose and disclose the problem that they have in the pelvis. And it represents around 20% of the gynecological visits for consultation of chronic pelvic pain, with an array of symptoms between the pelvis and the lower limbs. In the pelvis, it goes towards a chronic pelvic pain, dyspareunia, dysmenorrhea, and in the lower limbs in the form of a chronic venous insufficiency pain, in addition to different varicosities in the lower limbs and in the vulva. And looking to these symptoms, they are overlapped with a multitude of other systemic interrelated diseases like gynecological, urological, neurological, and gastroenterological, and with a sensitivity in the diagnostic modalities that decrementally decrease from the ultrasound to the CT. And this disease has two consequent ways of development. Is it the reflux that improves the compression at the compression sites, like in the left renal vein in the nutcracker syndrome, or the left iliac vein in the May-Turner syndrome? And this reflux causes decompression, but causes in the same way a pelvic pain in addition to lower limb and vulvar varicosis, or maintenance of the uncompressed vessels or the uncompensated vessels with the development of pain at the sites of compression, like in the left loin and in the lower limbs, with the franchise 6 leaking points starting at the internal duodenal and the obturator, superior and inferior gluteal, and the inguinal, and lastly the clitoral. And these leaking points are the mainstay for the development of different varicoses in the lower limbs. Even looking at the SVP classification of the pelvic congestion syndrome, going into depths of this classification, it seems a redundant classification, and it lacks an answer for many of the raised questions. That's why we have a complex relationship between the pelvic symptoms and the venous pathology, which is very different from the relation in the lower limbs. Multiple symptoms may occur concurrently with several potential pathologies, and similar symptoms may arise from disparate underlying causes. Like what? Like having chronic pelvic pain, which may result from gonadal vein reflux, May-Turner syndrome, or nutcracker syndrome. So this in turn will end with a diagnostic error in many of the cases, and is responsible for a lot of suboptimal results in many interventions. Looking at the diagnosis, still ultrasound is a cornerstone for the diagnosis. Two measures has to be taken. Is there a reflux? Can measure the diameter of the ovarian veins, and reflux is very important to look at, because reflux is present in all cases of pelvic congestion syndrome, apart from the 25% only in asymptomatic cases. So this gives a very high sensitivity towards ultrasound. Looking at the diameter of the ovarian vein, we will find that increasing the diameter of the ovarian vein from 5 millimeter to 7 millimeter will result in a positive predictive value from 71% up to 83%. On the other hand, MRA can give you many of the answers about the size and the reflux as well, and it is more sensitive than CT in the diagnosis, but it has only one limitation, which is lack for visualization of the reflux of the right ovarian vein. And in such cases, when you cannot see the reflux in the right ovarian vein, you got to do a direct venography in the course of intervention if the diameter is more than 7 millimeter. And lastly, the dynamic MRA, which has been used by the Hiromura classification for grading of the left ovarian reflux, whether it is maintained within the left ovarian vein, or it goes down towards the parauterine veins, or it crosses the midline to the contralateral side. So according to the SCVS and the American Venous Forum, there is a complete consensus toward the using embolization as the standard of care for patients of peripheral pelvic venous insufficiency, with an efficacy may mount up to 93%, with a complete regression up to 60% of the females. And there is sometimes a setback or incomplete improvement in addition to factors of failure, which may reach around 11% of the cases, with a predictors of failure. First of all is non-visualization of the right ovarian vein, or a diameter of the right ovarian vein more than 7 millimeter, or anatomical variation. We can go through some of the anatomical variations. One of them is the termination of the left renal vein. It doesn't end into the inferior vena cava, but rather into the left common iliac vein. So when you go through the IVC, starting at lumbar 1, and going down with the type of caster you are using, whether the Simon caster or the Cobra caster, you cannot find the orifice of the left renal vein. You go down, 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 you cannot find the orifice of the left renal vein, and eventually it turned out to be the left ovarian vein ending the left renal vein ending into the left common iliac vein. And when you go through, you will find that a termination of the ovarian vein into the left renal vein with a different termination. And when you do such a kind of embolization and ending with a complete ablation of the ovarian reflux. Other parts of the anatomical variation is a double ovarian, double renal vein ending separately into the IVC, and the branch from the ovarian vein or the termination into the inferior branch. So when you go through the IVC into the left renal vein, and you will find the wire goes again into the IVC once more without identification of the left ovarian vein. And you keep going through, you will find such a loop. You find a loop of the wire going from the IVC into the left renal vein, again into the IVC without visualization. But when you do a selective venography, you will find that the lower branch of the renal vein with the reflux into the left ovarian vein, and by selective cannulation of this vein, you will be able to do each kind of embolization and coiling. And lastly, you can see a case without visualization of the right ovarian vein on the MRV. And in such a case, you will find a very high resistance toward the cannulation of the left ovarian vein. And we have to admit that it's difficult to cannulate the right ovarian vein through a femoral puncture. It's very difficult. But in such a case, when you fail with cannulation of the left side, cannulation of the right side is surprisingly easier when you go through a femoral puncture. So we do a cannulation of the right ovarian vein through a femoral puncture with contrast opacification of the right ovarian vein. We're able to do coiling of this vein. We have some tricks to do. You got to rotate the caster to get in contact into the renal vein. You have to do oversizing. If you are doing an oversizing for an arterial stent of 10 to 15%, you do oversizing for the venous stent for around 20%, but for the coils, you got to do oversizing by 30% because of the high risk of embolization. This is a very important trick we got to take care of. And lastly, after embolization and sclerotherapy, you have a total ablation. One thing I have to comment about is how many coils are we using in embolization and the ablation of the ovarian vein? And most of us, we use 1 or 2 coils. What are the standards they are using in the Western countries? Around 15 coils. So we cannot afford such a kind of loss of money and our economic constraints, but we have to do a kind of manipulation of this part. 1 or 2 coils, do a sandwich technique, do sclerotherapy before to minimize the size of the vein and reduce the diameter, reduce the amount of coils you use, and again, put a kind of balloon inflation above the embolized part to minimize the risk of embolization, to minimize the size of the vein and the reflux, to enhance and augment the thrombotic process into the ovarian vein, and this would be cost effective in such cases. Lastly, when we have a pelvic congestion associated with a nutcracker syndrome or May-Turner syndrome, what to do? For the nutcracker, you can do just treatment of the nutcracker either by a renal vein transposition or a renal autotransplantation or ovarian vein transposition to the left gonadal, into the left iliac vein or the IVC, or you can do stenting of the left renal vein. But again, a very important trick, when you are doing a stenting of the left renal vein, your stent must be at least 16 by 60 millimeter, not less, 16 by 60. This is the only chance for your stent not to embolize into the IVC or into the pulmonary veins, followed by ablation of the renal vein. two last questions has to be answered. Do we have an ideal treatment for pelvic congestion syndrome? One of the methods is to do ablation of all the tributaries of the gonadal veins and the internal iliac veins, and this has been documented in some of the studies. Last question, when we do embolization of the emissary veins or the leaking points, is this gives an improvement of the lower limb symptoms? And the answer in this study is that lower limb doesn't get any kind of improvement after embolization of the vanishing points into the pelvis, but only the valval varicoces. I just recommend you a gentle recommendation of our oncoming meeting of the EGVASC on October the 3rd in Radisson Blu, and thank you very much.
For this nice presentation about the pelvic congestion syndrome, which is actually the percentage of pelvic congestion syndrome, we found it increasing today. Before that, we don't think in this pelvic congestion now. Every woman who will search for pelvic, it found it suffer from manifestation of pelvic congestion syndrome. Now I will present Professor Dr. Ayman Fakri.